So I'm Carolyn Applegate, as was mentioned earlier. My day job is I'm a genetic counselor at Hopkins. Today I'm really here on behalf of the National Society of Genetic Counselors, where I'm the current chair of the advocacy committee. And I'd like to thank the Every Life Foundation and all of you for attending today. And also, you'll see on my slides if I move them forward, Figure Drinker is NSGC's lobbying partner firm, and so they provided me with some of these slides. So I'd love to thank them. Kind of tell my age because I brought paper, but anyway. And sorry, that's a typo there. So first of all, I think a lot of times people say to me, and it's gotten better over the years, but who are genetic counselors and what do you do? And so for those of you who aren't familiar with us, we have master's degree training. What I love about my profession is that we combine both the scientific kind of molecular biology with medicine and with psychosocial counseling skills, and kind of bring those all together to try to help patients understand what their risks are, what they can do with that information in terms of treatment, diagnostics, as well as what does this mean for my family member. I think it's one of the most basic human things that all of us think about. Am I going to have what my grandmother had? Am I going to have what my dad has? You know, it's just something that we've all thought about throughout our entire lives, from basically the second you could think about things. And so our job is to make sure that people understand what we do know medically can be inherited and not, and make sure that people get the right testing, particularly as we're seeing more and more rare disease treatments becoming available. That lets us kind of has brought about some hope to patients, so that they can now just not know the information, but they can actually act on it and get the appropriate treatment and therapy. And genetic counselors are very trained in rare diseases. 80% of genetic disease or rare diseases have a genetic basis. And so we're trained on both the medical and psychosocial needs of patients and families with rare diseases. And historically, and I will hear this all the time, people say, well, aren't you just prenatal and pediatrics? And in my experience, I've been at Hopkins for almost 20 years, and I consider myself a peds genetic counselor, even though I'm about to tell you most of the time we see adults. So when I started, we had about 30% of our patients were adult patients. And now, about 20 years later, 70% of our patients are adult patients. And there's three main reasons I can come up with for that. One is that these rare childhood onset conditions, these patients, especially our metabolic patients with formula, are living into adulthood and living into, age 50, 60 even. We actually have some 70 and 80-year-olds when I think about it. But so one thing is just people are living longer. The other big thing is that people are being diagnosed. So we used to think that if you had a genetic condition, you were born with this predisposition, that you had to have it at birth. And of course, I think you all probably know this at this point, but even things like Parkinson's disease, dementia, later onset cancers, we now know the genetic basis to those. So that's really been in the last 10 years. And so we're really seeing this shift to our genetics clinics being filled with the adult population. The other thing about that is, I will say in our own specialty practice, we've moved the genetic counselors to work mainly with specialists in other disciplines, so the oncologists, the neurologists, the ophthalmologists, because many of the adult onset conditions are a single organ system, and so the specialists are really managing and diagnosing those, and then we save our medical geneticist colleagues for the pediatric patients or the patients that need that multi-system management, and then referring out to the specialists as needed. So, sorry. Slides. Okay. So as I said, we've had this increasing demand for services for adults and Medicare beneficiaries, but the Medicare program actually does not recognize genetic counselors as providers, and therefore does not reimburse genetic counselors for our services. And so this results in Medicare beneficiaries having a significant barrier to accessing genetic services. But it really, as many of you will know, impacts all patients, especially those with rare disease, because CMS typically sets the baseline for all insurers and coverage policies, and so that has an effect on everyone. And so without having an established reimbursement baseline, the other problem is that community hospitals and organizations can't afford to hire genetic counselors. You can't make that business plan to figure out how you're going to afford this. And so most genetic counselors, myself included, are concentrated in academic medical centers in major cities. And this means that we have patients traveling across the country sometimes, but even from, I'm in Maryland, obviously, Western Maryland, the Eastern Shore, crossing the Bay Bridge during the summer, for those of you who are local, coming just to see us when we could be doing telehealth. And so that is one, that we can get them covered, and two, to get telehealth. So the Access to Genetic Counselor Services Act, or HR 6280, or Senate Bill 3607, seeks to fix this by amending the Social Security Act to, one, recognize genetic counselors as providers and allow for direct reimbursement. It also will allow for telemedicine rather than patients having to travel to the big cities. So one of the other things is, why do we need genetic counselors providing genetic counseling, other than it's in the name? But one of the reasons is that it does help reduce healthcare costs. This was data I took from the NIH Genetic Test Registry just the other day. There's almost 65,000 genetic tests on the market, and genetic counselors are key to making sure that the right patient gets the right test at the right time. And that helps, one, make sure that they get the right diagnosis and treatment, but also it can reduce costs to make sure that we're getting the right test for that patient. And in particular, I will say, and I could tell a whole story on this, but this is an area, genetic testing in particular is an area where we see a lot of Medicaid fraud. And so billions of dollars have been lost when genetic counselors are not involved in this process, because other people, there's no kind of regulation to avoid those Medicare fraud issues. And so the bill, I would like to thank, like everyone else's, I noticed, it's bipartisan and bicameral. And I'd like to support our leads, Representative Adrian Smith and Kathy Castor, as well as Senators John Barrasso and Peter Welsh. And so my ask for you today, like many of my colleagues here, is to co-sponsor this bill. And I'm happy to take any information. I'm happy to talk to anybody if you have questions about that. We have over 300 organizations that support our bill, as well as 500 individual providers across all different medical physicians, physician assistants, and nurse practitioners. And I want to point out that we also cover pharmaceutical companies, we have support from laboratories, we have support from major academic centers and hospitals, and many of our support groups that are here today. And so it really is, a lot of people are supportive of this. I wanted to grab a little bit of data from our institution about telehealth. And so prior to the pandemic, our organization, we had basically no telehealth. We had one mini telehealth clinic that was based on a grant. But then with the pandemic, you can see here that the Medicare beneficiaries, it's the yellow line there, were actually using telehealth at least the same, if not more, than our general population. And for genetic counseling, we actually had 90% of our visits for both Medicare and everybody else were telehealth visits during the pandemic. And data from the CMS telemedicine trends report showed that 1 in 4 Medicare beneficiaries had at least one telehealth visit in 2024. And you'll see this decline that we've had over the years. And some of that is related to just providers preferring certain doctors and wanting to make sure that they can actually do a physical exam on the patients. But a big part of this is actually the instability with knowing when the telemedicine waivers are going to end. And so that brings me to my second request, and that is that Congress makes telehealth a permanent Medicare benefit. So continuing to extend the waivers is disruptive. It leads to institutions pushing for more in-person visits and reducing the number of telemedicine slots. And so if we really want healthcare to be affordable for all patients, particularly those with rare disease, where the only provider familiar with that condition can be hours or states away, we need to ensure that telehealth is a permanent option to provide that care. So with that, I will end.